Okay, next it is my pleasure to introduce Dr. David LILLICRAP to present in the spotlight von Willebrand disease. Dr. LILLICRAP is a professor in the Department of Pathology and Molecular Medicine at Queen's University in Kingston. He was a recipient for 21 years of a Senior Canada Research Chair in Molecular Hemostasis. In 2013, he was admitted to the Fellowship of the Royal Society of Canada. He is past chairman of the ISTH Scientific Standardization Committee, a prior member of the Council of ISTH, and in 2024 he was the recipient of the Society's Roberts Award. He previously served 7 years as an as an associate editor for Blood, and recently completed a 5-year appointment as co-editor-in-chief of the Journal of Thrombosis and Hemostasis. So welcome, Dr. David LILLICRAP.
Thank you for the introduction. Good morning, everyone. Thank you for asking me to give this talk this morning on not a rare disorder, but von Willebrand disease, which is actually the commonest inherited bleeding disorder, we believe. These are my disclosures. Okay, so I think most of you in the audience know that 99 years ago, this man, who was a physician in Helsinki, described a new coagulation disorder. So get ready for the centenary next year. There's going to be a lot talked about with von Willebrand disease. He described this disorder in this place in the world, this beautiful archipelago of islands, the Åland Islands. You see there's many, many islands here in the Baltic Sea in Scandinavia. And this is where the diagnosis was made, really. A young woman who is shown on this pedigree here with the red oval around her, Hjordis, bled to death from one of her early menstrual periods. She was 14 at that time. You can see in this pedigree that there are 5 siblings of hers who died before the age of 5 from severe bleeding. And we now know that this family had severe type 3 von Willebrand disease, and they bled significantly, this leading to the early demise of several of the family members. So, what's new? If you read about this guy, you know he want to know. He was a brilliant clinician scientist who not only found von Willebrand disease, but several other very important bleeding problems. So in the next 25 minutes, I'm going to discuss with you some issues about clinical evaluation, coagulation laboratory testing, some genetics, of course, and then I'm going to finish with about 10 minutes of discussion about new therapies for von Willebrand disease. So let's begin with, how do you make this diagnosis? Well, key to the diagnosis of von Willebrand disease is a clinical bleeding problem. And since work that's now been carried out over the past 20 years, many of you will be using scoring systems, so-called bleeding scores or bleeding assessment tools, or BATs. This was initiated back in 2005 by Francesco Rodigero in Vicenza, worked on by a European group. And then Dr. James, Paula James at Queen's, came up with a condensed bleeding score in 2008. And many of you now are using the ISTH BAT, bleeding assessment tool, which was first described in 2010. So here you see on this slide, if you look to the right-hand side of this slide, you see the abnormal bleeding scores or cutoff thresholds, which range from greater than 3 to greater than 7. The first 3 rows relate to females, so younger, middle-aged, and older females, where you see the scores increase from 5 to 7. And that's because the score that you develop is cumulative over your life. The older you are, it's more likely you'll have a higher score. And you can't get a lower score as you get older. It will inevitably stay the same or get higher. You see on the second from the bottom row that the score in males who have less hemostatic challenges, they don't have menses, they don't have postpartum bleeds, is greater than 4. And in children, because again, their experiences of bleeding is much less, the greater score, the threshold score is greater than 3. So I think these have been incredibly useful. You can say, well, haven't you been asking about bleeding forever? And that's true, but I think these quantitative analyses provides caregivers with a way of communicating relatively quickly about how severe a bleeding phenotype is. If I see Dr. James in the corridor or Dr. Liang, I can say I've just seen a patient with a bleeding score of 15. They immediately know that this patient has a severe bleeding problem. So I think that's actually a very important point here. And then the second thing, which relates actually to Dr. Hayward's talk, is that a high bleeding score gives a greater intensity for a laboratory investigation. Dr. Hayward would be more interested in working up to the nth degree someone with a bleeding score of 25 as opposed to a bleeding score of 5 or 6. Okay, so let's move to the laboratory. The standard measurement of von Willebrand factor is still the key to making the diagnosis of von Willebrand disease. You measure the amount of protein through the antigen test, and then you measure its activity by seeing how well it binds to platelets. And you must be aware that von Willebrand factor is highly variable time-wise. Particularly, it is an acute phase protein. So if someone runs to your laboratory because they're stressed or they're late for their appointment, they'll have a high von Willebrand factor level just because of that stress that they put themselves under. Now, in 2025, we have some good tests now, some better tests to measure the activity of von Willebrand factor binding to platelets. And on this slide here, I've noted several of those tests. The top row represents the original ristocetin cofactor test, which has a high variability and a low sensitivity. And then the 3 tests below that, particularly the one that's denoted at VWF-GP1BM, are tests that measure directly the way that von Willebrand factor binds onto platelets and produces its hemostatic effect. So why are these new assays? Many of you will be using these, I assume. Some of you may still be using the ristocetin cofactor test. That's not a bad test. It gives you a good result, but it is variable. So these new assays can be done on coagulometers, so they're automated. You can get a rapid turnaround time, which is very important in the perioperative time. They have very good sensitivity, being able to measure down to close to 1% levels, and they're highly reproducible. The coefficient of variation of these tests is around about 5%. With ristocetin cofactor assays, it's closer to 25%. So the old tests were much more variable than these new assays. Okay, now it won't surprise most of you in the audience to know that I'm going to talk a little bit now about genetics. And really the world of von Willebrand factor and von Willebrand disease changed dramatically over 6 months during 1985, when there were 4 laboratories which reported the cloning, the characterization of the von Willebrand factor gene. These were laboratories predominantly in the US and 1 laboratory in the Netherlands. So this gene is present on an autosome. It's on chromosome number 12 on the short arm, the P arm of chromosome 12. It's a large gene, and it has 52 regions of the gene, which together code for the protein, which we call von Willebrand factor. You can see there's a blue box around the middle part of this diagram. That indicates that exons 23 to 34 are duplicated on another chromosome, chromosome 22, in an evolutionary remnant of this gene called the VWF pseudogene. That's there just to annoy geneticists because it actually complicates matters in terms of genetic analysis. It has nothing to do with von Willebrand disease. Okay, so we know that von Willebrand factor, which is shown on this diagram here, is not an enzyme. It acts as a carrier protein for a whole bunch of different proteins and other things that circulate in the blood and outside of the blood vessels. I'm not going to go through this in any detail, but VWF binds and carries factor VIII, of course. Most of you know that, I think. It binds collagen in the subendothelial matrix, and it also binds receptors on platelets to produce the primary platelet plug that's essential in normal hemostasis. So this is information that's been gleaned now over the past 20 or 30 decades. And I wanted to just highlight a reference here that some of you may be aware of, but if not, this was published last year in a journal called Nature Reviews Disease Primers. There are 10 editors. You can see there's a couple of Canadians in this list of editors here. And this is I shouldn't be self-advertising this, but this really is a wonderful paper because it's very up to date and it's very comprehensive and very understandable, and it has pretty pictures. So this is just one of many pictures showing how von Willebrand factor is produced within endothelial cells. So if you're interested in this disease and you're not interested in listening to me this morning, which is understandable, then you should take a look at this, this review. It's a great review. Okay, so what do we do with this genetic information? Well, most of you know that we are using it increasingly for diagnosis. And as the first bullet here says, genetic testing for von Willebrand disease should be reserved for specific instances where you're going to actually alter the diagnosis or change the management or counseling of families with this disease. At the bottom, you can see that depending on the subtype of von Willebrand disease, it is either extremely helpful in type 2 and 3 disease, where you will almost always get a definitive, useful result, whereas in type 1 disease or low von Willebrand factor levels, only 2/3 of cases will give you informative results. So if you look at this diagram here, I'll go around from 1, 2, 3, and 4. You can see that genetic analysis is very good for confirming the diagnosis of 2A, B, M, and N disease, and we often get asked to do this in the laboratory in Kingston. And it's also useful to confirm type 1 when the levels are lower than 30%. Now you might say, well, why do I need to do that confirmation? And that's a good question. I'm not suggesting that all of your type 1 cases should be sent for diagnosis, but if you want an extra confirmatory analysis, we will do that. It's good for family planning and genetic counseling of type 3 disease, severe von Willebrand disease, and type 2N disease. And then in quadrant number 3 at the bottom left of the slide, it's extremely useful, really useful, for differentiating type 2N VWD from non-severe hemophilia A. You can't make that diagnosis really very well phenotypically. It's good for defining 2B disease from platelet type von Willebrand disease, which is a relatively rare disorder. And finally, in older patients, you may have patients who have what you think could be acquired von Willebrand syndrome or severe VWD. And so here I think genetic testing also provides a benefit. And then lastly, at the bottom right of the slide, we still use genetic analysis to further our understanding of pathophysiology of VWD. Now, this slide here, which actually again is taken from the review that I referred to a few slides ago, illustrates beautifully, I think, that the mutations, or these pathogenic variants as we now call them, tend to be clustered in certain regions of the protein for the type 2 forms of the disease. So if you go to the bottom of the slide, you can see 2N disease is the first of those type 2 variants. You can see those variants are clustered in the D'-D3 region. Similarly, 2M mutations are clustered in A1 and A3, 2B just in A1, and then in 2A disease, the mutations are clustered in areas where the protein is dimerized, multimerized, or cleaved by atom TS13 in the A2 domain. And then at the very top of the slide, the two rows there represent where the mutations occur, the pathogenic variants occur in type 1 and type 3 disease. And there you can see they're everywhere. And so when we get requests to do genetic analysis on type 3 or type 1 disease, we basically have to do analyses of all 52 exons. It's relatively time-consuming and not so easy to interpret. And actually, just in a response to the last question for Dr. Hayward's talk, increasingly genetic labs now are doing whole genome sequencing as a screening method. It's still relatively expensive, but the cost is going down all the time. And so for things like von Willebrand disease, whole genomes in which you slice the genome to look at a gene like VWD is increasingly what we'll be doing. Okay, so in the last 10 minutes, I want to now go on to talk about novel therapies for this disorder. And again, here are two very good references. The second one, you can see two of the co-authors are from Queen's, Jen Liang and Paula James. So this is an important area. And it's important in part because when you look at the pace of innovation for hemophilia versus von Willebrand disease, hemophilia A on the left-hand side and von Willebrand disease on the right, you can see that there's been a massive innovative tsunami for hemophilia and a trickle of innovation for VWD. So why is this? There's all sorts of questions that I think you can raise here, but we need to consider better things, new things to treat von Willebrand disease. And I'm going to very briefly now summarize 7 innovations that are either in the clinic or still in preclinical evaluation. So we would use these for prophylaxis principally or for treatment. The current strategies are listed on the slide. You know about them. Desmopressin concentrates estrogen and TXA. And the principal populations are in children, perhaps with recurrent nosebleeds, obviously with menorrhagia in reproductive age women, recurrent hemarthroses in severe type 3 disease, and recurrent GI bleeding. So here's option number 1. This is recombinant von Willebrand factor, von Wendii or Vevondi, depending on where you are in the world. This is made by recombinant cell preparation. It contains ultra-large VWF multimers, and it potentially would be useful in challenging cases like recurrent GI bleeding in patients with angiodysplasia. There's been a relatively slow uptake of this, but you can see at the bottom of the slide in the US between 2022, 2023, there was a very significant uptick in the amount of this material that was being used. Now, to my knowledge, there may be someone in the audience who knows more about this than me, we still do not have access to this in Canada. So recombinant VWF, I think, has not been approved in this country, and people are saying no. Yeah, so that's still the case, I think. So option number 2, which actually Dr. Khalifi was talking about with some of us about an hour ago, is this molecule, which you're all familiar with, emicizumab. So this bispecific antibody, which is being used a lot now in hemophilia, which is a factor VIII partial mimetic, can be used in von Willebrand disease in certain instances. Here are 2 papers that highlight some of those instances. So you see a paper at the top from Angela Weyand, which was the first report in which emicizumab was used in a child with type 3 disease who developed antibodies to von Willebrand factor. And then in the second paper, there are now about a dozen of these. This was emicizumab used in 2 cases, either with or without alloantibodies to VWF. So I'm not going to say much more about this, but you should be aware that if you have patients with severe disease where there's a low level of factor VIII, usually below 10%, and particularly in those individuals with severe disease who've developed antibodies to VWF, this bispecific antibody should be considered and is obtainable under special access in Canada, I gather. And so there's a trial ongoing. You can see here's the clinicaltrials.gov reference. They're planning on looking at 40 patients, and that trial may report, I would think, either later this year or next year. Okay, so options 3 and 4. These are both examples of universal hemostatic agents. Both of them are in early clinical trial phases. They have not been approved yet. The top one, which is made by Star Therapeutics, VGA-031, is an antibody against protein S, the anticoagulant protein S, and it basically enhances thrombin generation. And they are currently in the process of carrying out a study, a clinical trial in von Willebrand disease to see whether this enhanced thrombin generation can make a phenotypic bleeding disorder benefit in these patients. The second issue here, the second therapy, HMB-001, is made by this company called Hemab Therapeutics. This is another bispecific antibody, which, and I'll do my classical antibody mimic here, in one arm binds to factor 7, and in the other arm binds to the activated surface of platelets. So it brings factor 7 to the surface of platelets, which enhances hemostatic activity. And again, this is undergoing clinical trials at the moment, I believe, in Glanzmann's, but theoretically would be potentially applicable to von Willebrand disease in severe cases. So these are interesting agents in later phase clinical trials and could be used in actually any bleeding disorder where you do not have good treatment currently. Now, the next option number 5, KB-V13A12, is a bispecific nanobody generated by the group in Paris of Cécile Denis and Peter Lenting. Now, some of you will be aware what a nanobody is. It's basically a very small bit of an antibody. It's about 1/10 the size of an antibody. That produces actually some significant advantages in some ways. And you'll see at the top of this slide that this is 2 nanobodies held together by a linker sequence. One of those nanobodies binds onto albumin, and the other nanobody binds to von Willebrand factor. So this now joins VWF2 albumin and allows the von Willebrand factor to stay in the circulation longer by going through the neonatal FC receptor pathway, which is shown in the part of the slide on the left-hand side. So essentially this nanobody complex, this bispecific nanobody, is taken up by cells, the endothelium, circled through endosomes, and then spat out back into the circulation. And that extends the levels of von Willebrand factor, which increase over time. So the group in Paris have made a type 1 mouse. So these mice express about 11% von Willebrand factor. And when you treat these mice with subcutaneous injection of this bispecific nanobody, you can see that in the left-hand side of the panel, their von Willebrand factor antigen goes from 11% up to close to 25%, and that stays up for about 2 weeks. So, and you can see on the right-hand side, the same thing happens with factor 8 because its carrier is increased. This means that theoretically, a subcutaneous injection for a reproductive age woman who has menorrhagia could be given and would double, maybe treble the level of VWF over the period of time of the menses and would presumably reduce menstrual blood flow significantly. So this again is in preclinical evaluation, not yet available in the clinic. They also showed that when they cut the tail of these mice, that the mice did not bleed significantly. You see in the panel on the left-hand side, wild-type mice do not bleed. Type 1 mice had significant blood loss. And then the mice that were treated with the bispecific nanobody looked very similar to normal wild-type mice. One other quick comment about another option, number 6, HMB-002, again from HEMAB Therapeutics. This is another way of using the neonatal FC receptor recycling. It involves a monovalent IgG, which binds von Willebrand factor, takes von Willebrand factor through the FcRn bypass mechanism shown on the bottom of the slide, and increases the retention of von Willebrand factor in the circulation for a longer period of time. Again, you won't see this in the clinic for at least another 3 or 4 years if it survives preclinical evaluation and clinical trial analysis. So I'm going to finish now with option number 7. Here you see a paper that was published last year in Science Translational Medicine talking about the delivery of small inhibitory RNA to knock down the levels of plasminogen, which is one of the precursors of the fibrinolytic pathway. If you activate plasminogen, it produces plasmin, and plasmin degrades blood clots. So this has been trialed now in mice and dogs, and I'll show you also in primates, showing here in a dog study that when you give this subcutaneous injection, over a period of 40 to 60 days, you get a dose-dependent reduction in the level of plasminogen, and so you're reducing the fibrinolytic capacity of these individuals after a single sub-Q injection for an extended period of time. And so most recently, in Kingston, we have carried out this study in a group of 5 female non-human primates. And you can see in panel A, these individuals were getting intravenous infusions every 21 days. Their plasminogen levels went down to levels of about 20%, and they were followed over a period of 6 months. And at the bottom of the slide in panel B, you can see that these 5 female primates had significant reductions in the duration of their menses. So this anti-fibrinolytic mechanism, which ultimately we hope will be given subcutaneously once a month, appears to reduce menses in a significant way, as shown so far in animal models, most recently in these non-human primates. So this will be going through clinical trial evaluation, hopefully within the next 1 to 2 years. So in summary and conclusions, I think you can see that molecular science has dramatically advanced our understanding of the biology of this disorder and improved diagnosis. I think the utility of the bats has raised clinical awareness of bleeding disorders, not just for VWD, but for other disorders. There are several novel therapies, including different molecular mechanisms, which are undergoing early clinical trials. And increasingly, at last, and belatedly, I think we can offer personalized choices of treatments to our patients with von Willebrand disease. So I think he's happy to some extent, but he wants us to do more, and he's right. Thanks again for your attention.
We have time for maybe 2 questions.
Come on. If von Willebrand were in the audience, he'd be asking questions, I can tell you. Yeah.
Plasminogen deficiency can cause infertility. I'm just wondering.
Fibrinogen. Plasminogen. Yeah. So there are issues for sure. I mean, I'm not suggesting that we know the answers. If you reduce plasminogen levels down for an extended period of time, there are outcomes. We didn't see anything in the 6-month study with the primates, these membranes across the eyes and so on. So there are things that we need to be aware of, and we're investigating. Yeah. Yeah, Roy.
Khalifa from Ottawa. Your thoughts about von Willebrand factor collagen binding assays. So you've shown assays related to platelet binding. Are we missing a lot of patients because of collagen binding
Yeah.
assay not being available, or do you think multimers are enough to make that diagnosis?
So that's a very, very good question. We don't do collagen binding in Kingston. I don't know if any lab in Canada does collagen binding assays. We believe that collagen binding defects produce a relatively mild phenotype, but we may be missing those. And please do not send all those cases to us for collagen binding genetic analysis, because we may find variants and we're not able to interpret them. So I don't really have a good answer to your question, I'm afraid. Yeah, thanks for asking.
Hi there, David Page from CHS. My question's about transauricular vagal nerve stimulation. So I call that Star Trek meets Chinese acupuncture. I guess you've seen the presentations going into clinical trials in VWD. So any opinion on that?
Yeah, so someone asked me about this about 3 or 6 months ago. I gave a presentation and someone said, what about vagal nerve stimulation? I don't know whether any of you have heard of this. I certainly hadn't. I actually just about collapsed on the podium. So basically what this is if you rub behind your ear here, there's a way of stimulating the vagus nerve. And there is a publication that suggests that somehow stimulating the vagus nerve influences platelet activity. So it ultimately works through T cells, believe it or not, which somehow transmit signals to platelets to become more active. Is this going to be a future von Willebrand disease treatment? I have no idea. I'd say we were a long way away to saying that's going to be helpful. I'm not saying it's useless, but don't hold your breath.